Our next speaker is Keir Forgie, who will present on ex-vivo ex-situ lung perfusion with a porcine transplantation model. Dr. Keir Forgie is a PGY5 surgical resident in the Division of Cardiac Surgery at the Massankowski Alberta Heart Institute and the University of Alberta. He's a PhD student in experimental surgery focused on ex-situ lung perfusion. His primary supervisor is Dr. Jayan Nagendran, and his co-supervisor is Dr. Darren Freed. Here.
Hello, everyone. Thank you for the opportunity to come and share our lab's research. For anybody who's not familiar with ex-situ lung perfusion, it's very similar in concept to ex-situ heart perfusion, it's just the device is a little bit different. So there's a ventilator that continuously ventilates the donor lungs to keep them breathing, and that helps support respiratory function. And there's a pump that perfuses or flushes the vasculature with a nutrient-rich solution. And together, those two elements help support metabolic function, and they help keep the donor lungs healthy from the period of procurement to implantation, and in turn, increase the number of usable lungs for transplantation. Okay. I have nothing to disclose. In order for ex-situ lung perfusion to optimize the pool of donor lungs for transplantation, we need to reach continuous prolonged preservation periods of 24 to 48 hours. And this will allow for the elimination of geographic barriers and open the door for true global organ sharing. It will allow for ideal donor-recipient matching through more thorough and prolonged assessment. And perhaps most interestingly, at least in my opinion, is that it will enable or allow for the reconditioning of marginal quality donor lungs through the use of advanced cell and gene-based therapies that will require a prolonged dwell time with the target tissue in isolation from other vulnerable physiology. Clinically, the FDA has approved ESLP for about 4 to 6 hours of preservation. Preclinically, 12 hours is routinely published, either with or without transplantation data. And 24 hours of continuous preservation has been achieved, although without widespread success. So this table has a brief and select history of the progress made in continuous prolonged ESLP over the past 20 years. I'd like to draw your attention to the section in orange. In 2019, Transmedics, using the OCS lung device, was able to achieve 24 hours of continuous prolonged preservation in an animal model with successful acute post-transplant outcomes. In 2020 and 2021, the Edmonton group, so the lab I work with, and the Toronto group respectively, each attained 24 hours of continuous preservation. However, they did not have adequate reliability to attempt transplantation. And it's important to transplant to be able to validate the box run data in an in vivo setting. So the objective of this particular study was to refine our protocol for negative pressure ventilation ex-situ lung perfusion to achieve reliable, that is greater than 80% success in 24 hours of preservation with assessment and acceptable in vivo transplantation data. In a nutshell, we took 12 lung blocks from juvenile pigs, attached them to our machine and ran them for 24 hours at normothermia, which is 38 degrees to 39 degrees for pigs, for the record, perfused with a cellular perfusate and a low flow, which is our standard protocol. Half of those lungs were then randomly selected, and the left lung from the block was transplanted into a recipient pig, monitored for 4 hours before a final isolated left lung assessment to evaluate the transplanted lung function. So these are the various parameters of our protocol that have been modified or refined during the course of my PhD. There's too much detail to go through there, so I think a summarized slide is better. Essentially, we have lung protective perfusate and lung protective ventilation and perfusion strategies. On the perfusate side of things, we use a buffered cellular perfusate that's hyperoncotic, which helps guard against edema formation in the lungs. We supplement the perfusate with packed red blood cells, which of course have buffering capacity and also supplement the oncotic pressure and then increase the oxygen carrying capacity of the perfusate. And then we also add nutritional supplementation to the perfusate through the use of TPN and vitamins and insulin and glucose to help support rehabilitation. On the perfusion side of things, we perfuse at normothermia. We use a reduced flow rate, again, to guard against the development of pulmonary edema. We diligently keep our pulmonary artery pressures under 20 and ideally target them between 10 to 15 millimeters of mercury, again, to guard against high hydrostatic pressures. We will tolerate a mild permissive alkalosis, which helps protect against acute episodes of increased pulmonary pressures, particularly in the early phases of ESLP when the systemic inflammatory response is most strong. And we reduce the number of evaluations that we perform, which occur at 50% of cardiac output in an effort to improve the VQ mismatch, recruit more lung units, and get a better sense of the overall lung function. However, the trade-off is with the increased hydrostatic pressure, you shift the Starling equation in favor of extravasation of fluid and more edema formation. In terms of ventilation, of course, we use negative pressure ventilation, which we demonstrated in 2018, results in less lung injury, less barotrauma, and lower rates of or lower levels of pro-inflammatory cytokines in the perfusate compared to a strategy of positive pressure ventilation, ESLP. We will use classic lung protective ventilation strategies, but we also accept very low tidal volume ventilation in line with some of the ICU literature on very severe ARDS management. And that just depends on how the lung's behaving on the machine. And we virtually eliminated recruitment maneuvers, which can be damaging, cause iatrogenic injury to the lungs because it's simply not necessary with negative pressure. In terms of the results, I've compared our 24-hour outcomes to our historic 12-hour controls, and that's just to help gauge the quality of preservation. So moving left to right across the screen, you can see that dynamic compliance, pulmonary vascular resistance, and the percentage weight gain per hour are not significantly different between groups of lungs that were run for either 12 hours or in the 24-hour group. We did notice significantly higher pulmonary artery pressures at the end of 24 hours. However, the mean pulmonary artery pressure in that group was still well under 20, actually quite close to 15, which meets one of our acceptance criteria for transplantation. Now, the PF ratio is an assessment of gas exchange or oxygenation in the donor lung, and it's long been considered kind of the gold standard or king of the hill assessment parameter for accepting lungs for donation. So I have it here in isolation compared between 12 and 24 hours, and you can see that there's no significant difference between group. And in fact, the mean PF ratio at the 12 and 24-hour groups is well above 300, which meets another one of our acceptance criteria for transplantation. It's also noteworthy that all 12 of the lungs in this sample made it to the 24-hour endpoint, so we had 100% reliability in this sample. Now here I have the PF ratio comparison pre and post transplant, and you can see that on the isolated left lung assessment, there is a significant decrease in the quality of oxygenation of that isolated left lung, which is to be expected due to ischemic reperfusion injury post-transplant. However, the mean PF ratio in that left lung is still above 300, which is an excellent outcome in the acute post-transplant period. And if we were to score that using the 2016 ISHLT PGD grading system, PF ratio over 300 would be a grade 0 if we had normal chest x-ray. Unfortunately, we don't have chest x-ray data, so we have to assume we're somewhere in the vicinity of grade 0 to 1, which is still a phenomenal outcome. Now, I don't have any histology to share with you today, but I do have some images of the gross anatomy. So I took a lung block that I felt was representative of the sample, and you can see pre versus post ESLP, there's very little change in the overall appearance of the lungs. And I can attest that any transplant surgeon would be quite happy to implant lungs that look like that, as long as their physiologic parameters were also good. So of course, we've got study limitations. We're dealing with a small sample size. Follow-up would ideally be 48 to 72 hours or longer. And of course, there's no cold static preservation control group. In terms of future directions, we're interested in attaining 36 hours of continuous preservation with transplantation. So I've got some preliminary data to share with you. I've added a column to the previous graph, which shows our initial results with 36 hours of continuous preservation. And you can see that compared to 24-hour preservation, there's no significant difference in the PF ratio. And this is based off a sample of 5 lungs, all of which made it to the 36-hour endpoint. So we have plans to attempt transplantation. Unfortunately, it's probably not going to happen in the course of my PhD. Now, 48 hours of continuous preservation would be the holy grail within our lab. And we do have some initial success in approaching this time point. So I can show you here, we have an N of 1 with porcine lungs that made it to 42 hours, and also an N of 1 of discarded human lungs. So lungs that were not accepted for transplantation clinically and were donated for research. You can see at the 42-hour time point, both of them have PF ratios above 300, which is very encouraging. I think this result will be achieved probably before the end of my residency. So in conclusion, we have a reliable 24-hour negative pressure ventilation ESLP protocol with acceptable post-transplant oxygenation. We also have preliminary evidence of a reliable 36-hour preservation protocol and plans to attempt transplantation. And this opens the door for greater collaborative research opportunities in the realms of cell and gene-based therapies that could hopefully improve organ function while on the machine and perhaps increase long-term survival in the recipients. I'd like to thank the following people and funding agencies for making this research possible. In particular, I'd like to thank the CDTRP for the travel award that made it possible for me to join you here today. So thank you very much for your attention. I'm happy to take any questions.
We'll start with any questions from our colleagues attending virtually. No. Okay, go ahead.
It's very nice work. I do similar stuff, but with the kidney, I have a couple of questions. One is, one of the criticisms whenever I try to publish this kind of stuff is we're using I imagine this is a syngeneic model, correct?
Sorry.
Like
Yes.
it's syngeneic, right?
Yeah.
So if you were to have an allogeneic transplant, would you expect anything different at such short time points?
It's really hard to say. It's one of those crystal ball questions with such short time points. We've never seen anything along the lines of hyperacute rejection, but they're syngeneic. So I don't know the answer to that, to be honest.
And the second thing is, so you were talking about adding additional maneuvers to enhance preservation. What kind of things in the kidney we use? Gaseous transmitters, for example, at our center to enhance or to minimize injury. What kind of things would you do in lung?
Well, there are a number of studies that are looking at individual pharmaceutical agents that have shown benefit already, but they just haven't made their way clinically. So I think there'd be a lot of opportunity just to go through the literature and cherry pick out some of those elements. But I'd be specifically interested in applying maybe some monoclonal antibodies to try and decrease the amount of circulating resident immune cells, so that when it comes time to implantation, to see if you can decrease the severity of that initial immune response. That would be something that I'd be quite interested in looking into.
Very good. Thank you.
Yeah.
Yeah. Did you manage to measure the wet to dry ratio of those lungs post-transplant?
Yeah, so that's a good question. We don't do wet to dry ratio in our lab. It's just not part of our standard protocol, although it's often what is published. Generally, what we do is just a pre versus post ESLP. And so where I was comparing different preservation durations, it didn't make sense to show absolute weight gain. So I did it per hour, and the per hour weight gain was similar. It's a really good question, because I see it as being the fundamental limitation to us achieving even longer preservation standpoints. It's just the progressive development of edema. And in that respect, I think we are getting very close to kind of hitting the peak in terms of what ventilation and perfusion strategies we can modify. And the secret is really going to be within the perfusate itself to guard against, deleterious edema formation.
Before we get to the next question, I understand there's a virtual question.
Yes, hello. Thank you very much for that excellent talk. I have a question in the chat from Dan Harvey. So the question is, excellent work and great presentation. Are you measuring biotrauma inflammatory profile, and oxygen indices don't correlate very well with outcome in ARDS, so acute respiratory distress syndrome?
So we do look at pro-inflammatory cytokines during the ESLP run by taking perfusate samples and running ELISAs on them. I didn't share any of the results here because it becomes very difficult to compare the inflammatory profiles across such different durations. What I can say is that we didn't notice any significant difference in the pattern of pro-inflammatory cytokine generation between 24 and 12-hour ESLP runs. And unfortunately, in terms of the transplants, despite our best efforts, we have not been able to actually identify a spike in pro-inflammatory markers as you would expect post-implantation. So that's something that's a bit of troubleshooting still required in the lab to figure out how we can capture that data.
Thank you. That's a great presentation, Murat. It's lesser of intensivists. And so I'm going to ask a question from a perspective of intensivist who takes care of patients with sick lungs. So I understand positive pressure ventilation, not so much negative pressure ventilation. And so why choose negative pressure ventilation over positive pressure ventilation in your specific preservation technique? And the one thing that we commonly look at in positive pressure ventilated patients is that PEEP, or positive end expiratory pressure, may impact PF ratios. And so how do you take care of that in your negative pressure ventilation model?
Okay, good question. So in terms of your first question, the primary benefit of negative pressure ventilation is that you're able to maintain a much lower mean intra-alveolar pressure because you don't have that pressure support above PEEP exposure. And although we'll end up with a transpulmonary gradient that's perhaps comparable, it's really the fact that the alveolar epithelial cells are not exposed to that intermittent high pressure episode. So that's at least our theory as to why the lungs also seem to recruit much more easily with negative pressure. And that part I can't explain. And then, sorry, can you repeat your second question?
So for your outcomes, you looked at PF ratios.
Right.
And PF ratios can be made better by using higher PEEPs, right? So if there's epileptic lung, if you use higher PEEP and you resolve atelectasis,
Right.
your PF ratio will be better.
Right.
So how you're accounting for those differences, and is there an opportunity for a trial maybe comparing?
That's a good point. I guess one of the ways that we control for that is that all of our evaluations are performed at the same ventilatory parameters. So we try to keep PEEP as low as possible. And in the very beginning of our runs with these juvenile pigs, that can be as low as 3. But for the most part, it's set at 5, and that's how we always evaluate them. We make sure that our peak intrathoracic pressure is also standardized. So that's an effort to try and compare. And then hopefully anytime we're evaluating near the end of the run, that the lungs are fully recruited. And so we're not having a lot of variability between some lungs being particularly atelectatic and others being fully recruited. But we're also dealing with healthy lungs in this situation, which is another point you made. And that's simply because you have to walk before you can crawl. And once we've perfected this with healthy lungs, we'll start, injuring them a little bit, I guess.
And then last question to Dr. West.
Yeah, so this is really, I love this stuff. It's so interesting. To my knowledge, nobody else is using negative pressure ventilation in the ex vivo or ex-situ models yet. Is that still true? And because it's such an interesting premise and the early results are so impressive. Is that being picked up in other places? Do you know?
I've come across a few small animal studies, so rat models that have implemented negative pressure, but certainly there's nobody else that's using it in a large animal model. So that's unique to Dr. Freed and Dr. Nagendran, which is one of the reasons I signed up, because I thought it was such a unique opportunity. Yeah.
Great.
All right, thanks again.
Thank you very much, Dr. Forgie. When there's lots of questions, it just is an indication of how fascinating the topic is.